So in order to determine the optimal sequencing of therapies, we think about both these treatment characteristics and the patient characteristics. And I think that as I'd mentioned before, we're very fortunate to have a number of treatment options available. It's just that we don't have high-level evidence or clinical trials that can tell us how to select these therapies and in what order. I will say that in the last few years, somatostatin analogs have really come out as a preferred first-line therapy for grade 1 and 2 NETs. And I think this is for a couple of reasons. First, their toxicity or side effect profile is very favorable. Side effects for SSAs like octreotide or lanreotide can include some mild GI upset, occasionally some fatigue. For patients who still have a gallbladder, it can predispose them to development of gallstones. But in general, they're well tolerated and don't cause what patients often associate with chemotherapy side effects. Many of our patients with newly diagnosed metastatic NETs are actually asymptomatic at the time they're diagnosed. So I tell patients I don't want the fix to be worse than the problem. And so that's another reason why SSAs can be a great first-line choice. And in addition, if we can control their disease, so prevent new spots and prevent further growth, SSAs can achieve that. I'm also pretty clear with patients when I'm talking with them that SSAs are unlikely to shrink their cancer. I think just talking about goals of therapies very clearly with patients as you're choosing them, like what is the goal of treatment for you? So I explain that, and that's okay. So for patients with NETs, achieving tumor control for many years, as long as patients are feeling well, preventing growth, preventing new spots is still considered a success. In terms of thinking then about second and third line therapies, I think that really depends on those treatment characteristics and the patient characteristics we talked about before. So for example, if I have a patient who has pre-existing lung condition, we know that everolimus can have a low risk of causing pneumonitis. So this may not be an absolute contraindication to selecting everolimus, but it may weigh into my decision. I will also, I'll pose just another question and then I'll answer it, which is, what is the situation when SSAs would not be first-line therapy? And I think that there's a subset of patients who have particularly patients with pancreatic NETs who have bulky disease, symptoms from tumor bulk, and maybe have a slightly higher Ki-67, perhaps a grade 2 tumor, who are really in need of tumor shrinkage. As I mentioned before, these SSAs do not yield tumor shrinkage. So in this case, I might choose something like the combination of temozolomide and capecitabine. These are two oral chemotherapy agents that have been proven recently in a large randomized study called ECOG 2211. This was a study that I led that randomized temozolomide capecitabine versus temozolomide alone. And in that yielded about a 30% response rate or shrinkage rate. So I think that's probably, and that's really just in pancreatic NETs, not proven yet in small bowel neuroendocrine tumors or in lung NETs.